thank you everybody who is attending this super interesting meeting. I'm extremely pleased, I'm extremely happy to have here with us Edith Pomarol-Clotet. She is a good friend. She's a psychiatrist. She leads the Spanish network on schizophrenia research, which includes more than 20 centers around Spain and doing some network research, and has an impressive career over the last few years in neuroimaging and understanding the schizophrenia symptoms. That will be the talk. But I would like perhaps go back a bit of time. She was also someone here in Cambridge. He was here at the beginning of the brain mapping unit, at the beginning of the clozapine clinic long ago, back with Herman Berrios, with Peter McKenna, and with Ed Bulmore long ago. And actually, at the time that she returned back to Barcelona 6 years ago, in 2006, 2005, is when I met her, and she strongly recommended me to move to Cambridge. And I have forgiven her, and which has taken a bit of time, but thank you very much for the advice. And I'm super excited today about the talk, because it's something I'm personally interested in, and I think there is a few members in the audience that are really interested on what is the phenomena that she will be explaining, which is mostly about the negative symptoms and how that will be developed through, finally, whether imaging can help us to understand a bit negative symptoms. Edith, benvinguda, welcome. Thank you very much. The floor is yours.
Thank you. So, okay, first of all, I would like to say thank you to Emilio for the presentation and for the invitation, and also all the organizers. And as Emilio said, I was here about 18 years ago, and for several years in the brain mapping unit. Well, first in Fulborn with Berrios and Peter McKenna, and then in the brain mapping unit with Ed Bulmore, John Sackling, Paul Fletcher, Graham. So after that, I went back with a grant that was called like the reinsertion of the researcher to their country, something like that. And since then, I've been in Barcelona, keeping research in imaging. And now I'm back here in Cambridge with a grant, a mobility academic grant, for several months to do and establish some more research again in the brain mapping unit with Ed. And also, you are all very welcome if we can establish collaborations, or you think our studies are of interest for you. So this is the point that we came back here for several months, so you are all welcome. So for a start, as the title says, is on the trail of schizophrenic symptoms, and like already said Emilio, it's more about functional imaging, if it really can help us a little bit in understanding what is all this about. So you all know that schizophrenia is a severe and chronic psychiatric disorder, that it has high rates of devastating symptoms and course of the illness. And you all know that symptoms really segregate to all these three groupings, and it's assumed that there is a different physiopathological basis of these three syndromes. So why do we think it's important to study symptoms? Well, we are of course not the only one, but also the AIMH, so the National Institute of Mental Health in the States, are promoting what is called the Research Domain Criteria, RDoC. And what they do really say? Well, as it is written here, they promote examining psychological constructs or concepts relevant to psychopathology, rather than focusing on mental disorder categories only. And why do they think this is important? What they argue is that if we study just categories or diagnoses like schizophrenia, maybe we'll have to deal with lots of heterogeneity. So patients, as you know, are very heterogeneous. Some have some symptoms, the others don't have them. And also what they say is that these illnesses have lots of comorbidity between each other that also brings confusion. And another thing that they argue is that categories also have lots of subclinical subcategories that also brings more noise. So what they promote is why not to focus in symptoms, and maybe it will be a way to better understand what is the neurological basis underlying this mental disorder. And also another reason why maybe symptoms are interested to be studied is that personalized treatment. And as you know, there are these transcranial stimulating therapy, but also there is this deep brain stimulation that, as you know, is already wide used in Parkinson and other neurological diseases, but also is starting to be used in psychiatric disorders. For instance, 3 years ago, we in Barcelona, with another group from Barcelona as well, we did the first study that showed in 8 patients that deep brain stimulation had a positive result in resistant schizophrenia. But the point is where to place these electrodes. And by doing this research of trying to capture or identify these brain abnormalities targets, maybe it could be a way in the future that we can go directly to these targets and these brain alterations. So, as Emilio said, we were interested in negative symptoms. As you know, there you have like apathy, blunted emotional expression, poverty of speech, but also we thought they were interesting because they are resistant to treatment with antipsychotic drugs, and also, as you know, they are associated with poor functional outcome. So it's very associated with poor functionality in daily life patients. And this is important for patients. So what are mainly the 2 theories of negative symptoms? Well, the one that was first theory of negative symptoms historically is that it is a psychiatric equivalent of the frontal lobe syndrome. And one line of evidence is that apathy and poverty of speech of patients with negative symptoms resembles that of patients with the frontal lobe syndrome, like in neurological patients, for instance, who have had a stroke or a tumor or brain injury. So another line of evidence is that executive function, that is also related to frontal lobe, is impaired in schizophrenia. Of course, this is not so simple because there are other cognitive areas such as long-term memory or sustained attention that are also affected in schizophrenia. And the final line of or piece of evidence is that executive impairment correlates with negative symptoms. However, again, it's not so simple because also does disorganization. So one way to test this theory is by functional imaging. And this has an original study done by Liddell, that all of you will have heard of Liddell, who did a study that it was a resting pet study, and he saw a correlation between this frontal lobe and negative symptoms. However, it was not clearly replicated. And then most studies have used fMRI with executive tasks, different types of executive tasks. And the problem is that the findings have not been consistent and they have been very mixed. You can see this review by Gogari et al. So one reason why maybe these studies have not had consistent results is because executive tasks do not capture the everyday problems that frontal lobe patients have. They do not capture apathy or particularly goal neglect, where the patient failed to initiate or it has fragmentation of complex goal-directed behavior. This is now well recognized in neurological patients that even when they have terrible problems with voluntary behavior in daily life, they can pass or they do not fail these standard executive tests. So Chalice and Burgess, and in 1991, so a long time ago, made it clear that this problem was with testing executive function. So they developed what is called the 6-element tests, in a way to test this goal neglect that is clearly close to apathy and lack of volition. So, which is the 6-element test? As you can see here, there are 6 different tasks. Two of them is with tape recorder, they had to do some dictation. Then there are 2 sets of pictures where the patient had to name the picture. And also there were 2 sets of arithmetical problems. So what you have to say to the patient is that in 10 minutes, they have to do at least some of these tasks. And what you see is that patients who have goal neglect do not organize themselves, and even sometimes they stick in only one of these tests. So here we see that there is a computerized version of this multiple element test, and this was developed again to assess goal neglect in brain injury, and it was a good correlation with other multiple tests, and also was scanner friendly, that it was important for us, and also had a good ecological validity. So this submit that this computerized multiple element test, what needs is to perform different subtests to achieve the overall goal. So we did our own paradigm, that it was a modified version of this computerized multiple test that we saw. And what we did is the patient just was inside the scanner with the goggles, and then he could see this video game where he could play inside the scanner with the 2 fingers moving from right to left the car to get some petrol. And then it moves to another video game where the patient again could move from the 2 fingers, this little bar, gray bar that you see here, to get the balloons. And then after they had another video game, and the patient could move again the bar to keep moving this ball. Or again, it changed to another one, and here you move the bar to move the ball to break all these bricks with different numbers. But the real paradigm where we are addressing to goal neglect is here, where there is another block where there is a voluntary switching. And this means the patient was looking, for instance, at the same video game, but in this time, he was able to choose when to move to the other video game. And what we told the patient is that he was going to have these different video games, and he had to play in 48 seconds a little bit of each. So the patients, when they had this voluntary switching, had to keep in mind that they had to organize time for changing to one game to another to be able in 48 seconds to play with all of them. And what happens here? Well, we did first a paper with healthy subjects that Abigail Gee, also it's an author that maybe is here. And what we saw is that when patients did this task, behaviorally, patients did less voluntary changes, and also patients had greater deviation from optimal playing. They were not able to play all the games more or less in the same time. Of course, they didn't have the watch to see, but they had to keep it in mind. And when we compared absent negative symptoms with high negative symptoms, we saw that we didn't reach significance, but there was a tendency, again, in both, in not being able to change so well with the different video games, and also in not performing with the same time for each game. So, but what did we see in the scanner? What did we see in the images? So healthy subjects really do an activation while they are doing this organization or planification of the game, in an activation on the frontal areas, as you can see, lateral frontal areas, and also parietal. When we saw the mean activations of 25 absent negative symptoms, as you can see here, there is a little less activation of these same areas. And what happens when we have high negative symptoms? Well, clearly, we can see here that when over 24 high negative symptoms patients did this task, they really were not able to activate the brain in the same areas. So when we did a direct comparison, what we find here between 23 absent negative symptoms versus 24 high negative symptoms, we can see here the brain areas that are hypoactivated, that is bilaterally lateral frontal cortex, especially in patients with high negative symptoms. And also you have a bit of parietal. So then we moved to another theory already of negative symptoms. And this one way, this another theory is more recent one, and it reflects that maybe negative symptoms, it's reflect reduced responsiveness to rewarding stimuli. And this is important for the dopamine theory of schizophrenia. Thus, as you may know, for a long time, people have speculated that whereas positive symptoms are due to functional dopamine excess, negative symptoms might reflect functional dopamine deficiency. And this is important because dopamine is well known that is involved in reward processing and motivation. And what is more important of all is that dopamine codes for what is called reward prediction error. And what is reward prediction error? Well, you all know that if behavior is rewarded, it will be more likely to be repeated in the same circumstances, and vice versa. If reward is punished, it will probably not occur in the future. But the main important thing here is that learning is the difference between predicted or expected reward and the observed reward. And this is what really drives learning. The difference between expected or predicted reward and that of observed reward. So here we have again our task in the scanner. And as you can see here, what the patient does in this reinforcement learning task is that the patient have two stimuli and have to choose one and press a button, and then this will be either rewarded or not. So here you are, imagine you are in the scanner, and then you choose one of these symbols. You choose, and then you see that it is rewarded with euros that we really give at the end of the session of the scanner when they come out. So if you have done this, you would again press, imagine, if you have another set of these stimuli and you press the other one and you see this with no money, probably in the next one you have been learning and you will press the one that you have seen reward. So the way it works is that we have two blocks, and one block is the paradigm condition or reward condition, where is 80% of the stimuli have a reward. So you keep learning that that symbol has more reward and you keep pressing it. And you compare it to another comparison that is random, the reward answer to the symbol. So, of course, then when we compare one block to another, the one that has the paradigm where you have a learning and a reward processing going on, compared to this other test that has no rewarding because it's 50%, you see the areas that activate with the reinforcement learning task or with the reward. So which are these reward predicting error associated brain activations? So here you have controls, and you can see that there is this activation in the ventral striatum and also in frontal areas that it has been well established, like inferior orbital and also even dorsolateral. Again, when we see these 27 patients with absent negative symptoms, what we see is that they have a little bit less activation, but pretty similar. And when we have the 27 high negative symptoms, as you can see here in the brains, there is a bit of ventral striatum, but the frontal parts are really with very little or non-activation. So when we did the direct comparison between absent and high negative symptoms, what we saw is that patients with high negative symptoms, while doing this reward prediction error task, did not activate the inferior orbital part of the brain and also dorsolateral. Since what we expected really was that patients were going to have a ventral striatum abnormality, but we didn't find it, we did what is called regions of interest to try to have more power. And again, when we did it, and you can see here these plots with healthy controls, absent negative symptoms, and high negative symptoms, we see that the only differences came in the orbitofrontal cortex, both left and right, that they are also areas for reward processing. So what can we conclude, at least from these studies, is that we can give support for the frontal lobe theory of negative symptoms, even though in the past there are some mixed results in previous studies. At least with this study, with the CEMET task, that is maybe more sensitive to goal neglect, maybe we can have this more robust result with this hypoactivation in the frontal areas. But also, we find support for the reduced reward responsiveness theory, but qualified, because even though we have had results in the inferior frontal orbitofrontal cortex, we have not seen differences, at least in ventral striatum. But at least with negative symptoms, with both studies trying to address the two different theories of negative symptoms, that from frontal lobe and also that one from reduced reward responsiveness, seems that there are some support for both, and in both implies more the frontal lobe. So here we finish with negative symptoms, and we can discuss these results later. And we move to another syndrome, that is positive syndrome, that is delusions and hallucinations. And what we know is that this positive syndrome is more responsive to antidopaminergic drugs, and most studies have been doing in hallucinations more than in delusions. And I will just show, and I will finish here my talk, about hallucinations. So we have again two theories of auditory hallucinations. One is the one that is called the perceptual or neurological model, and this says that voices are due to spontaneous or irritative neuronal activity in the auditory cortex. And this goes back to Kraepelin, but was supported in the 1960s, a long time ago, by Penfield, who was doing surgery in patients, and he was stimulating some, when the patients were awake, some cortex areas. And he saw that when he was stimulating the temporal cortex, patients said that they heard voices. However, the voices were a bit complex because, for example, one patient said that he could hear a conversation that he had with his sister 30 years ago. And this is not very similar or doesn't resemble the type of voices that our patients have. Another theory is that it's called cognitive models that have inside the cognitive models two theories. But the cognitive model theory, what it says is that voices maybe are due to misinterpretations of cognitive activity as perceptual. And one is this one of Chris Frith. He was the earliest version, that is that inner speech fails to be identified as self-generated. In fact, comes back with Chris Frith saying that this maybe is part of this idea that it is a failure to monitor will intentions. And if this failure to monitor will intentions applies to action, maybe we would have passivity ideas. But if this failure to monitor will intentions applies to inner speech, maybe then patients have this feeling of hearing voices. The other, even more influential idea or theory is that one of intrusive memories or vivid memories misinterpret again as perception. And here comes the ideas of some precedent for PTSD, post-traumatic syndrome patients, who said that they experienced voices and they related to traumatic experiences. However, again, sometimes what they explain as these voices are a bit different of what our patients do. So, one way to examine the perceptual neurological model is the one that is used, that is called symptom capture. And this study has been done already a long time and several studies. The problem here is that the studies, if you really read the papers, there are very few subjects. And again, the results are a bit inconsistent. There is a better study with a bit larger that was Sommer et al. That found more clear activations in Broca's, Werniger's, and supramarginal. And in this paper, they also claim that they also found activation in the right supratemporal gyrus, say in the auditory cortex. But if you really check, it's only 11 voxels, so it's a bit more difficult to know if only with this little activation it's meaningful. So what we did is to do our own study. And what we did is another, we tried to do a paradigm, a modified paradigm of this symptom capture. And what we did is to, before the patient went to the scanner, to ask them to tell us what do their voices say. So we wanted them to repeat out loud their voices. And we recorded the voices, what they say, the voices, and we transcribed those voices. And what we did is we then put the patient in the scanner, and the researcher just repeated what the patients have said. So just in the scanner, the researcher just repeated the same content of the voices that the patient had explained. And what we said to the patient is, please, while you are in the scanner, every time you listen, you hear the researcher saying whatever your voice say, please press a button. So the researcher was saying several times the voices that the patient had, and he was pressing the button. But we also said, please just press the button when you hear your own voices. These are patients that are constantly hearing voices. So in the scanner, they also had some of these voices, and they had also to press every time they say they hear the voices. So what happens? What happened? Which images we had? When we checked the speech perception, so when we check what all the times that the patients could hear the researchers talking with his voices, we saw a very strong activation, that you can see here all the temporal, of the auditory cortex, because in fact they were really listening, the researcher saying their voices, and also other areas like our Broca's, Wernicke's, supramarginal, and precentral. But what happened when the patient said that he was hearing his own voice? So we see that there is again an activation, but this time there is no activation of the auditory cortex at all, but it does have activation of the language areas. So here we have the patient with the real auditory stimuli from the researcher, with this strong activation, as we have seen, of all the temporal, that it's the auditory cortex plus the other areas. But when the patients press the button saying they hear voices, here we have no auditory cortex activation, but just an overlapping in language, supramarginal, precentral, and other areas. We wanted to be sure, because we were expecting as well again some activation of the auditory cortex. What we did then is a region of interest analysis to see if with getting more power, we could see some differences. And here, as you see, there is this A, that is the Herschel gyrus, that is part of the auditory cortex. And you can see here some dots, and these dots, what they mean are the individual mean activation values. So you can see here audios and voices. And you can see that the mean activation of the individual mean activation of the patients are activated left and right when you hear the audios in this area, this auditory cortex area, but as you can see, there are no activations when you hear the voices. So our patients did not activate those. And what we do as well is that that you can see in the right is that time series plots show group signal change in the same region of interest, so in this auditory cortex area, Herschel, in the time window spanning 4 seconds before to 10 seconds after the stimuli presentation. So here you can see the red color is when the patient heard the researcher. As you can see, there is an activation in both left and right of this area. But as you can see, the green line, there is no activation when they hear the voices. So again, we had the same result. When we do this to other language areas like Broca, Wernicke, and also, I have not shown here, but supramarginal and precentral, what we see is that both audios and voices do a very similar pattern of mean activations and also of time series. So what can we conclude? Well, the idea is that our study finds no support for auditory cortex activation during the experience of hallucinations, but we do find activation in language areas. So maybe this means that voices involves mechanisms that participates in the processing of speech. But since we don't have activation in the auditory cortex, maybe this processing of speech is at the level of the coding linguistic properties of speech rather than its initial detection of auditory perceptual qualities. And another interpretation of this maybe is, since the areas that we have seen activated are this Broca area, supramarginal, precentral, and even supplementary motor cortex, these are regions that are engaged during verbal short memory or articulatory lobe. And this equates to some extent with the concept of inner speech. So maybe we can give support for a misidentified inner speech theory. And what about the other theory that was intrusive memories? Well, from our study at least, there is little to suggest activation in these memory-related areas. In fact, and when you do a task of an autobiographical recall or autobiographical memory, the brain activates what is called the default mode network. That is the medial frontal cortex, posterior cingulate, but we did not find in these patients any activation of the default mode network, so it seems that we cannot support, at least in this study, these memory-related areas like being related to voices. So I think here we have our group in Barcelona. I think maybe you know Peter McKenna, who also worked here for a lot of years in Cambridge. Then he went to Glasgow. Then he came with us in Barcelona. Or maybe you know Raymond Salvador, that is also this month here in Cambridge, and Paola, who was also here for a period with all of you. So thanks to them, thanks to you for listening. And if there are any questions, I'm very happy to be able to discuss them with you.
So thank you very much for the impressive and super interesting talk, Edith.